Carl, you have been involved with treating patients with congestive heart failure for many, many years, and we're going to go into that pretty deeply. But before we do, would you mind just giving our audience sort of a thumbnail sketch of your career in medicine?
Sure. I started practicing at the Duluth Clinic in 1979. And at that time, there was diagnostic coronary angiography and 3 drugs. So I kind of like that. I was always interested in angiography and also the pathophysiology of congestive heart failure. So my practice evolved to the point where I was an interventional cardiologist and dealt with heart failure. I did inpatient and outpatient consultation. I served as chair of my department. I served as vice president of the Duluth Clinic. And then when we were about 480 docs, I served as president of the clinic. And then I retired as the chief medical officer of Essentia Health. And at that time, we had about 780 docs and 16 hospitals and 62 clinics. So I've had just a fantastic professional life.
Yeah, well, congratulations on such a award-winning career, let's say, and congratulations on your recent retirement, which I know you are enjoying, and I appreciate you taking time out to come talk to us today. Tell us a little bit about what made you want to launch the congestive heart failure program that is the subject of the article we published in our past conversation.
Well, I can tell you that when I was in training, like I mentioned before, I really found the care of patients who had heart failure. I found the pathophysiology intellectually stimulating. I found the treatment approaches stimulating. But what I found when I got into practice was that I really couldn't care for these patients in the way that they really needed to be cared for. I had a busy practice. I did consultation. I worked in the cath lab. I did outreach. And I also lacked some of the skills, some of the knowledge that the patients needed. And a small group of us, in fact, 3 of us, sat down and thought there has to be a better approach for caring for these patients. There has to be a way that we care for not only the patient who has the disease, but the patient, he or herself, and also the family that's involved, because diseases like this really impact the patient and their caring community.
What was going wrong? You say they weren't getting the care that they deserved or needed. What was most typically going wrong, or that was most bothersome to you?
What bothered me a lot was patients were being readmitted. It's easy to initiate the appropriate therapy, to put them on a diuretic regimen. It's hard to understand all the psychosociological components of patients with chronic and terminal diseases. So I would see patients who had a limited lifespan, wasting that limited lifespan by being readmitted into the hospital. So they're getting sick, that takes time. They're in the hospital, that takes time. And then they're recovering, that takes time. And we're just taking these precious time away from the patients and away from their families, that we needed to keep them home and we needed to keep them viable and allow them to enjoy the time they had left.
Carl, before we go any further, I want to be, aware of the fact that not everybody that is on the call now or will listen to this recording after the fact knows a whole lot about congestive heart failure. It is a term that is confusing to many people. Can you give us just the basics and talk about some of the common misunderstandings about the condition?
Well, first of all, there are people who think that the diagnosis, using the diagnosis of congestive heart failure is wrong. It's scary. I kind of come from a different perspective. I think it's real. It tells patients exactly what's going on. It's much more understandable than phrases like Stephen Johnson syndrome or acute myocardial infarction. So when you give that diagnosis, you have a heart that's failing. So it can fail in a couple ways. It can fail in its ability to pump appropriately so that you have good circulation throughout the body to carry out its functions, which is systolic failure, or it can fail diastolically, where you don't receive the blood the way it should. Patients become short of breath. They have significant edema. They become profoundly fatigued. It's a condition that the majority of time cannot be cured. It can be treated. There are rare instances where it's reversible. It has an overall prognosis that's worse than cancer of the pancreas. It's a significant event. It's a significant disease process.
Yeah.
I want to ask about what patients typically misunderstand about their condition. But before you answer, just a quick courtesy to our audience. If your phone is not currently muted, would you please mute it? And then only unmute if you want to ask a question by voice. Carl, what is the typical misunderstanding that patients have about congestive heart failure?
I think that basically, let me use some non-cardiology terms. I think that basically patients get sick and they usually come to see a doc or another healthcare professional, and they think that they can give a treatment or a surgery and they're cured. So-called technical fix. I think the real understanding or the misunderstanding is that this is something that requires an adaptive challenge for them. This is something that we're not going to be able to cure. This is something that we're going to be able to treat. And I think that once that is understood, then it's easier for these patients to follow the appropriate advice. I think that they don't understand that they need to at times have a significant change in their lifestyle. I think all this causes for the patient and their caregivers and their family significant depression at times, and they don't understand how that interfaces with the appropriate therapy. So that's the way I'd answer that, Chris.
Yeah, thanks very much. You wanted to build a program for patients that are contending with congestive heart failure. Many of these patients will also be contending with other diseases. One registrant in advance asked in particular about pneumonia. And I'm wondering how that complicates the way you design the program. Can you focus just on congestive heart failure, or do you have to think more broadly about the range of medical conditions that patients might have in your program?
So my perspective on that is that when we developed this program, you have to realize that this was years ago. And so we would tell our primary care physicians that we are there to help you take care of these patients. Most physicians are paid on a production basis, and there's sometimes concern that you're going to be stealing the patient, okay? The other thing about it is that we're a cardiology practice. We're not endocrinologists. We're not infectious disease docs. And so we built a model that is a collaborative model. We have a team-based approach to the care of patients. And so if a patient presents to us, if we're their door sometimes into the healthcare system for ongoing issues, we work collaboratively with a primary care physician. We facilitate the interface between the primary care doc and our program. We do not treat their diabetes. We do not treat their pneumonia. We do not treat their hypertension per se. We do not treat their depression per se. But we communicate after each visit and at any event that requires communication with the attending physician. So it's a collaborative process. And what our docs have learned over time is that if we help them take care of patients, if the patients have good outcomes. Patients are pleased with our care. They're pleased with the doc's care also. And so it's a very much of a collaborative effort. And I think an important aspect of that is that all of our activity occurs within the house. It's not outsourced to a third party. And therefore we have a common medical record. We can exchange information. And it's that entire team that cares for the patient. We don't try to do all things, but we try to facilitate the care for people.
Yeah, terrific. I mean, that's always a crucial choice, thinking back over the many programs we've talked about here, is how you define the patient population. Thanks for clarifying how you think about it, which is to focus on the congestive heart failure and focus on good coordination with other physicians.
Right.
Makes complete sense. Let me invite our audience to ask questions again at any time. This program is for you, and I want to make sure whatever's on your mind gets addressed. I'm prepared and more than able to carry the conversation for the hour, but would be just as excited to have some input from you. So if you have any questions or curiosities, please feel free to raise your hand or to type a question into the chat box. Okay, so way back in the late 90s, 1998, you decided you wanted to do something about it, and you decided to commission a team to take on the care of patients with congestive heart failure. Was that a weighty choice, just the decision to commission a team, a small one at that point, for nothing else but caring for this group of patients full time? So
let me just go back, Chris, a little bit to answer that question, set it in a context. Old guys like me, we always set the context because it just takes a while to get there. But we decided and we felt that we could not care for patients in the way that they needed to be cared for. There are so many things that you have to watch. You have symptoms change, laboratory data, psychosociological issues. You just can't do that in a busy practice. So one of my partners, myself, and a nurse sat down and we spent several months putting this together. We knew we didn't have the experience, the expertise, the skills required. We knew that as docs, so we didn't have that all within ourselves. So it wasn't so difficult. I think that I learned a lesson. Let me try to answer this in another way. I learned a lesson early on. I had a patient, bed 8, CCU. I still remember her. Very, very ill. I would see her 2 or 3 times a day. I was worried she was going to die on me. I spent a lot of time with her. My nurse spent a lot of time with her. She got out of the house. She did fine. I randomly, walking down the hall with my nurse, ran into her. And of course, I was a hero, okay? But what she did is she ran up and gave my nurse a big hug and thanked her for everything that she did for her and said, "Hi, Dr. Heltne." Now, that was a point that really changed my perspective. There's a lot more that goes on in caring for patients beyond understanding the pathophysiology, understanding the therapeutic opportunities, to a more holistic approach to it. And so we knew, Jim and I knew, that we needed more help caring for these patients. So it wasn't that difficult once we crossed that threshold.
All your comments are very well received, and certainly a consistent characteristic of the people that I've spoken to about similar initiatives aimed at other types of patients is that all have come to a point where they've recognized that they as a physician can't do it all. The care need is greater than either their time or their skills, and so they recognize that a team-based approach is more powerful. Any reaction to the specific question of what made you want to find one or two or three people who would do nothing else but focus on these patients, as opposed to having a larger group of people maybe giving a little bit of their time here and there to care for these patients? Was that a significant choice?
You really can't take care of these patients on a part-time basis, Chris. I mean, these patients, they have a chronic condition, they have a terminal condition, and you need to stay on top of it. You need to know what their symptoms are. You need to know whether they're gaining weight. You need to monitor them very closely. This is not just something that you do on Thursdays, okay? These patients need constant attention. And the real trick is to figure out how to do that in a way that can be most cost effective, most resource efficient. That's the trick. But the problem that I think occurred in caring for these patients by physicians alone is that they were seen in the office, and then you'll see you back again in 3 months. But a lot occurs the next day, the next week, and the next month. And if you're going to help them preserve and enjoy the time that they have left, they need to be constantly monitored. Their drugs need to be titrated. It requires a dedicated, programmatic approach and a dedicated team, from my perspective, to do this appropriately.
Mm-hmm. Step us through the program from the patient's perspective, if you don't mind. So if I'm the person who's been hospitalized, what is my introduction to your program, and what happens step by step?
So that's evolved over time. Now what happens is, and then I'll go back to previous time. Now what happens is that when patients are admitted into one of our hospitals here, I'll speak primarily in Duluth, is that the patients are admitted, they have a diagnosis of congestive heart failure. They're seen in-house by the staff from the heart failure program and then referred into the program. All patients that are referred into the program, starting back when we initiated the program, needed to have their diagnosis confirmed. We had the experience of being involved with St. Louis County and their patient population, who had their care management done originally by their third party, or their insurance. And half of the patients that they listed having heart failure never had heart failure. So what happens from the patient's perspective is, first, they're brought into the program. The first thing from my perspective is to confirm that we have the right diagnosis, that we haven't missed something that's reversible. Then to make sure that they have an understanding of their disease process, which is not a one-time 30-minute lecture, but an ongoing education, not only for the patient, but for the family. Then having them understand what the correct therapy is, to be able to effectively and safely titrate the medications to the literature-supported levels that help take care of the patient. Looking at them from the standpoint of depression, talking about what their goals are so that they can, I was talking to Denise just prior to going online, and it's much easier for patients to become compliant when they say, you know, I really want to walk my daughter down the aisle. That's what I really want to do. Instead of talking to them about, well, you need to have a low sodium diet and et cetera, but looking at what their goals and desires are, and then helping them understand through education what they need to do in order to achieve that goal, so that they're really involved and committed to their therapeutic options.
Lots of hooks you've just left. A number of ways we could go with the conversation next. you gave us a good picture of some of the first steps. I've got one listener who's very interested in a question that I think a lot of people will be interested in, and that is, can you tell us who's on the team? And give us at least a bit of insight into what their roles are on the team.
Well, I'll give you my perspective. You have to remember that I'm retired at this time, Chris, but the team involves nurse practitioners or physician assistants. The team involves RN. The team involves nutritionists. The team involves and has involved in the past people from our psychology department. So it's a holistic approach to these patients. The folks have a lot of responsibilities. They see the new patients, make sure that they have the right diagnosis. They titrate the drugs to the appropriate levels, making sure that the patients are tolerating the drugs, that there's not laboratory data, renal insufficiency issues, those type of things occurring. We use telescales. It varies depending on what year you look at the data, anywhere from 15 to 20+% of the people. So those telescales allow us to effectively monitor the patients. So they look at that on a daily basis, and based upon the scale, the weight, plus the answer to 10 yes or no questions, can tell whether the patient is stable or whether they need to get a phone call. That team works on collaborating with the primary care physician. They work with the cardiologist if they need EP services, if they need an LVAD, if they need coronary angiography, so that they have that total responsibility, frankly, of caring for the patients. This is a program, and we mentioned this in our conversations before, that once a patient's in the program, they're cared for by the staff of that program. They see their attending cardiologist probably every 6 months or a year, unless conditions warrant that they be seen sooner. So the NP, PA, RN, the nutritionist, the psychologist are all involved in the approach to this patient.
It sounds like probably the nurse practitioners and physician assistants each have a panel of patients that they take care of. Is that accurate?
Well, I think that that's accurate. I don't know, I have a hard time with the word panel. I would say that that they are nurse practitioners and physician's assistants see designated patients that they care for on a regular basis so that they have that relationship with them. But again, it's a team, Chris. You know, it's everybody involved. It isn't just a nurse practitioner. It's a nurse practitioner, the nurse. It's what we call a HUC or office assistant. It's the primary care doc. It's the attending cardiologist. It's a whole team.
When you first launched this program, it couldn't have been obvious how many patients a single nurse practitioner or physician assistant could look after, for example. How did it become clear how this model would work?
I'm not sure. I think we just kind of evolved organically. We started out with one nurse practitioner and one RN and one part-time office assistant. And we have evolved now, I think, across the system. We have 2,800 patients in the program. I'm going to ask Denise. Denise, how many people are here in Duluth at this point in time?
We have 5 advanced practice providers, but keep in mind they also do our AFib clinic as well.
All right.
So
there's 5 here from the nursing staff seeing these patients now.
One of the areas that I'd love to learn a little bit more about is the way you zero in on the right dose of medications for each patient. That's come up again and again in our conversations. How hard is it to get the accurate dose, and how do you get there? And what are the consequences if it's not quite right?
Well, if you look at the study, this is primarily dealing with ACE inhibitors and beta blockers. Because those two classes of drugs have really made a difference in the quality of life our patients have, and a little bit of difference in longevity. And so there were a number of studies done that showed what the optimal dose was of an ACE inhibitor and a beta blocker. The reality is that you can't start with that optimal dose. It takes a physiological adaptation to get there. You also have to look at what is happening to the renal function, what is happening to the potassium, all those factors. So the right dose is really guideline based, okay? The art to this is to effectively titrate the drugs to the level that they should be to meet guidelines. Now, when we started our program, you look, there's a lot of literature saying that this should be the appropriate dose for an ACE inhibitor, or this should be the appropriate dose for a beta blocker. But if you looked at how that was deployed, about 40% of the people were receiving the appropriate dosages, okay? And as a busy doc, working in the cath lab, doing consultations, being on call, it's really difficult to titrate those drugs appropriately. And this is where the programmatic approach, delegating this among many other activities to the nurses, is extremely helpful, because they are able to titrate the drugs appropriately. And in our program, up to 90 to 95% of the patients are on the appropriate dose and the appropriate drugs for the care of patients. So we use the guidelines, the American College of Cardiology guidelines, the American Heart Association, based upon the literature, evidence-based, but the real trick and the real art is to titrate these drugs in a way that the patients can tolerate it, which you can't do, I don't think, in a busy practice as effective or as efficiently.
Yeah, and if it's that important to get the dose right, then of course it's very important that the patients understand just how important the drugs are and how important it is to take them properly.
And that's why going back to understanding what the patient's goals are, because you're much likelier to get patients committed to the lifestyle changes, to the therapeutic options, if they understand that this is to reach a goal that they have defined themselves. So I think that that's a very important starting point.
I want to ask you about diet, because I know that's another important area, but even before I do that, I want to acknowledge the several questions that are up on the chat board, all of which I've received and will be working into the conversation shortly. So thanks for asking them. I will be getting to them. But diet is another important factor. Talk a little bit about what work is necessary to get patients eating properly to take care of their congestive heart failure.
Well, a couple things is, one is, the foundational element with diet is a low sodium diet for our patients. Again, going back to what the patient's goals are, and then having them really have the appropriate education to understand the complexities of a sodium-restricted diet is important, not only educating the patient, but educating the patient's family so that they understand that. We had an interesting case study. We had a patient who was on one of our tally scales who every Thursday his weight would go up. And we could not figure out exactly what was going on. Well, what was going on, we finally figured it out, was that on every Wednesday he went to the local school and he read books to the third graders. And then as his reward for spending his time, he went and had school lunch, heavy sodium, and that's for his sodium went up. But I think that, you know, we focus on to make this program work. We focus on making the right diagnosis. We focus on education. That's a lot to do with the diet. And then we focus on the right therapy, all within the context of what the patient's goals are.
Could you talk just a little bit, Carl, about how this program affects the day-to-day work lives of other physicians, either cardiologists or other docs, and whether you've run across challenges from time to time in getting everybody's and sustaining everybody's support?
We ran, to be honest, when we started the program, we ran into a lot of resistance from primary care physicians, in that their feeling was that we were, to use a vernacular, stealing their patients from them. It took a lot of time and effort for them to understand that we were working together for the patient's benefit. And so now a lot of that worry has been taken off their shoulders. For me, as a cardiologist, I was able to work in the cath lab, do my interventional practice, run a busy outpatient and inpatient consultative service. We live in a rural part of the country, so that I, at least once a week, would fly 80 to 120 miles away to do consultations. I didn't have to worry about whether these patients were being appropriately cared for, because I knew that we had the staff who had the skills, the expertise, the knowledge to do for this. So I was able to concentrate on these other aspects of my practice and not worry about doing an adequate job for these patients.
Great, thank you, Carl. Listen, I know that you're a cardiologist, but you've also been a chief medical officer. I'm wondering about how generalizable your program is, or at least the principles underlying your program. Could the same or a very similar program be extended to many other medical conditions? And I've got one listener today who's very interested in the extent to which a program like this could be employed in an ICU to help take better care of patients as they're discharged from the ICU, regardless of the medical condition that landed them there.
I think that there can be a long answer and a short answer to that. As CMO, I spent a lot of time working on our primary care practice here. And I think that there are specific chronic diseases that can be managed by this approach. You can see it in heart failure, you can see it in diabetes, you can see it in asthma, those type of diseases. I like the idea. So I think the principles were set out by Wagner way back at the time we started this program. I think the principles are applicable to a lot of disease processes, but you can't subset a patient and have them being cared for in multiple different clinics. You have to pick the one issue that's predominant. I really like the idea about the ICU outpatient approach. And when I served as chief medical officer, I worked with two really great people, Dr. Mike Van Scoy and Kathy Van Ruden. And what they did at that time was they put together an instrument that looked at claims data, pharmacy data, hospitalization data, the diagnosis that the patient had, frequency of admission, frequency of emergency room visit. And with that instrument, we're able to subset our patients into a cohort of patients that required intensive care as an outpatient. And then if they had a predominant problem of heart failure, they would go to the heart failure program. But otherwise, there was a care team that dealt with managing the care and assisting physicians and others in delivering the care. So I think I think that that's the way to go. I had read that comment in the information you sent to me before, and I really think that we could take much better care of our patients. We could steward our resources in a much better way if we develop that model of practice beyond heart failure.
You know, many of the illnesses you may be contemplating right now may occur near end of life, and I'm wondering what your team has learned over the years about easing appropriate entry into hospice or palliative care programs when the time.
Well, that's an interesting question, because when we started our program, you know, I reviewed 1,000 patients with congestive heart failure. And, you know, the mortality is worse than cancer of the pancreas. Many of the patients I reviewed their chart, they're deceased, so the mortality rate is very high. We needed to help them transition into the hospice environment and the hospice care. And initially, we ran into some resistance from the staff of hospice because they're so used to taking care of mitotic diseases rather than heart diseases. But now that relationship is very good and very effective for our patients. And that's part of the discussion that occurs with the patient over the time when we kind of create the holding space for them to have that discussion within this program. Hospice is a critical element of this. And our experience, to repeat myself, is that it took time for the hospice staff to understand that these patients have some unique needs. For example, a patient who may want to live long enough, have a good enough quality of life in order to have some seminal event in their life occur, a wedding, a graduation of a grandchild, something like that. You might end up putting them on a pressor agent, which causes their sense of well-being to be better. It might decrease their lifespan, but it gives them the quality of life to be able to have that event. Our hospice nurses, if you would have talked to them about putting them on dobutamine or dopamine, they couldn't understand that. So it takes a lot of work with them so that they understand this. But it is you know, we're taking care of patients who have a chronic terminal disease. We need everybody's help to do that appropriately, so we focus on the patient's goals.
It sounds like a whole a topic that could easily take up a second hour if we had it, Carl. Given the limited time we do have, I want to turn to the question of resources for programs like yours. Thinking back even to the origin of the program, I know that you had to overcome some resistance in the form of concerns that your program would lose money.
Yeah.
Could you share a little bit more about the type of resistance you faced and how you overcame it?
Well, a couple things. One is that when we started the program, there was really no reimbursement for care management. There was no reimbursement for telescales. I think, frankly, the way we were successful, excuse me, in doing this is that I come from cardiology. cardiology in my time is a profit center in places such as ours in integrated systems. So we had the desire to provide the appropriate care, and we frankly had the financial resources to do that. The problem was that was dealing with our payers. It was a problem. It still is a problem. The incentives are not aligned. I think I mentioned to you that I had this fantastic experience. I was trying to get one insurance company, one of our payers, I won't use the name, to give us some reimbursement for caring for these patients in this manner. So they took a group of their patients that we cared for. We followed them for 6 months, and I really learned a lesson, because at the end of the day, we saved that insurance company $1.25 million, and I got a plaque. And there's just something wrong here. There's just something wrong with the way incentives are aligned. At this point in time, you know, our nurse practitioners and PAs have billable hours. They get, I think, 80% of Medicare. RNs are primary incident 2 billings. We do have some ACO contracts with CMS. We have some ACO contracts with others. It's kind of evolving and changing. We do, with some, get a per member per month management fee. In some payers, we get reimbursement for our scales. But I think, again, the incentives are not aligned appropriately. You know, you're paid for doing procedures. You're paid for technology. We need to pay for this type of care in a better way.
Carl, after every conversation like these that we have here monthly, I feel frustrated that somehow it's easier to get reimbursed for a pill or a device of dubious effectiveness than it is to get reimbursed for care management that saves money and improves patients' lives. Such is the system we have.
Chris, could I just add to that? Because I mentioned that I reviewed 1,000 patients, and I just want to tell you what I found out about mortality and readmissions on those patients, if I could, because there's not a lot of pills or devices that would do what this program did. So with reference to a survival advantage, the 30-day mortality for patients post-discharge nationwide had been about 11.3%. In our program, the 30-day mortality rate is 3.7%. Our patients not in the program, it was 9.4%. The 60-day mortality rate was 5.9%. The patients not on the program, 4.5%. There has been data showing that there's been about a 22%, 23% readmission rate for these patients. Our readmission rate for heart failure after heart failure is 5.4%. You can't do that with a lot of technology. You can't get those kind of results with some magic drug. You can get it by approaching the patient in a programmatic way, a team-based approach, using the knowledge, the skills, the expertise of everybody within that team in the most effective way. I think that these results speak to the importance of this approach to care, and it's so difficult to get payers to really understand that.
I think it seems safe to say that if your program had been a drug, it would have been hailed as a blockbuster.
Yeah.
I want to honor a couple questions that came in very recently. I confess I don't know northern Minnesota very well. I've only visited the southern portion of the state. But the questions relate to the social determinants of health and relate to the possibility that some of your patients may be living in poverty, may have material needs, housing needs, food needs. And the questions ask, does your program attempt to deal with those needs in addition to what you've already described?
Yeah. You know, I'll try to answer that. I'll do it this way. When you asked me, Chris, to give you a thumbnail sketch of my professional career, I mentioned that I understood the pathophysiology well of patients of heart failure. I understood the therapeutic approach, but I frankly, as a young doc, didn't really understand the complexity of patient care. Okay, that's those socioeconomic impacts. We live in an area where Essentia Health in this region, over 60+% of our patients are Medicare patients. We have a lot of dual eligible patients. We are mission-based, a mission-based organization, physician-led, physician-directed, mission-based organization that cares for patients. That's our mission. So we cannot cure poverty, but we work very hard to ensure that all of our patients, no matter what their means are, get the appropriate care. In our geography here, we're mostly, we have maybe 2 micropolitan communities. Part of our service area is, frankly, by census called frontier. Population density is small, or is very small. So when we talk about caring for these patients, we focus a lot of time and effort on those aspects that really affect their ability to receive appropriate therapy. And that's why I think that the person who mentioned the outpatient ICU was spot on. You have to be able to manage the care for these patients who are dual eligible, who are Medicare, and you have to take all that in consideration, or you're not really effectively caring for these patients.
Thank you. You mentioned in our conversation that one of your disappointments was having to watch the reality of your program or programs like it not spreading quickly across the country, even though they were so effective. Do you have any advice for people who want to get programs like yours off the ground, or for the chief medical officers in their organization who might want to support them?
Well, I guess what it sounds a little ephemeral, but what worked for me is probably the following things. Going back to try to live the mission of what our profession and what our organization is. And unabashedly and frequently stating that. Number 2, understanding the financial realities, designing your program in a manner that is so that you're the best steward of your resources, and then presenting to the resource allocation tables within your organization. This is why, based upon the mission. This is the results that we can obtain for our patients. This is the costs that we will incur. As we get more into value-based reimbursement, I think it may be easier, okay? I think it requires a lot of persistence. What was nice for me is that I work within an organization that physician-led, physician-directed, they really supported innovation. What was nice for me is that I had wonderful nursing staff, nurse practitioners and PAs to work with. that really cared for patients, not just caring, but cared for patients. So that in fact, although I played a role in developing the program, I had the right staff to offload this to so that they were able to go forward. I think you just have to be a strong champion for this type of approach and be persistent. It doesn't. It's not something that you can start within 6 months. It takes time to get everybody aligned.
These hours always go by way too fast for me, Carl. I've learned so much, and I thank you for spending some time with us today. And I think the way you ended it was perfect, just acknowledging the staff that has made your program or the program you launched run so well. Yours may be the one that runs most independently of ongoing physician supervision or leadership that I've looked at. A real credit to your team. I want to thank personally both Denise Buxbaum and Linda Wick, her predecessor, who spent time educating me on the program in advance of this event. Thank you, the two of them, so much on my behalf. And Denise, thank you if you're still in the room and can hear my voice. But Carl, I know that you had to drive a long way to participate in this call today. I appreciate your time. Thanks very much.
I appreciate the opportunity, Chris, and I really appreciate you shining a light on this way of caring for patients. I think that we can do a much better job, be much better stewards with our resources if we pay attention to the innovations that you are bringing forward to us. I just want to close this, I teach physician leadership, lead faculty for that at a university down in Minneapolis, and I'm now asking them all to be looking at your regularly scheduled innovations here. So